please, Dr. Okano, you can turn on the presentation from Japan, please. It's this IgG4 lecture, yeah. Yes, please. We have no sound.
cells, fibrosis, and phlebitis. Sinonasal lesion is not focused on the comprehensive diagnostic criteria for IgG4-related disease. Rhinosinusitis often accompany with IgG4-related ranges from 30 to 6%. And besides IgG4-related disease, IgG4 positive cells in nasal polyp tissue and serum IgG4 level can be a biomarker reflecting the severity of CRS with nasal polyps, especially post-operative recurrence in eosinophilic CRS. And I upload my pre-recorded video in a symposium, so you can see my video during the conference or even after the conference. Okay, so just sorry for the delay to participate in the symposium.
Okay, thank you. We cannot play because you don't run your video and we cannot run your slides without, so do you suggest that we skip your presentation as it came during the session actually? So you can...
I think Dr. Okano's uploaded his session.
Sorry?
And it can be seen. No, I know, but he says that we can watch his session online later, and that's what we would like to do. Thank you very much.
So I suggest that we then continue the discussion on the previous, because I think that you can certainly teach young doctors here some things about disease they would not see.
We should ask Dr. Trimarchi and Dr. Okano a question from the audience.
Yeah. Does anyone has a question for Dr. Trimarchi? Nobody has, I have a question actually. So we see patients who were on cocaine and even on heroin in their intranasally, who had lesions, but when we did the biopsies, we've seen that the crystals related to granuloma was something which was put in cocaine, which was some other powder, which we could not precisely analyze, but we were sure that it's cocaine. So do you have evidence besides genetics, which doesn't say that it is cocaine, the reason, but do you think that cocaine is the only possibility to cause directly the molecule of cocaine would lead to granulomatosis, or is it just the foreign body or some immune process? Did you understand my question? Yeah, we don't hear.
Yes, I think. Good morning to all the chairman. Well, I think that if the problem would be the external duster granuloma, all the patients using cocaine would have this kind of problem. But the point is that on millions of people that are using cocaine, there are few of them that develop so impressive practice. That's why we are thinking that there might be a genetic problem, because we are visiting a couple of people using cocaine in the same time, the same amount of cocaine, and the wife has a nose completely destructed, and the husband no. That's why we think about the genetic hypothesis.
Yeah, what I was suggesting is that maybe it's not the cocaine molecule itself, but the process which happens in the nose in some people would lead to autoimmune disease, localized or systemically even later on. But in cocaine, it's usually local. What I was asking actually, do you think that the molecule itself or the person or genetic background is responsible? So, because I've seen perforation with elevated ANCA in a heroin user who inhaled, sniffed heroin, and he had ANCA positive, whether he was vasculitis disease due to heroin, was it the trigger, or would he have it anyway? I'm not sure. I mean, I did not study, you studied things, so that's why I'm asking.
But regarding ANCA positivity, we discussed a lot, Professor Specs, and
we lost the sound.
Hello?
Yeah, now
Can
we
you
hear
hear
you. Yeah, now we hear
So,
you,
I think that ANCA is a phenomenon, and that they are not involved in the pathogenesis.
yes. Okay. Do you have any questions regarding these cocaine lesions of granuloma with anyone from the audience? Okay. So should we continue the discussion from previously? I would ask you, Valerie, something with sarcoidosis, which you didn't mention that much, and it's my experience. I have 5 patients with sarcoidosis in my whole career. I both biopsied them, one had operation due to lacrimal sac dysfunction, and they tend through time to go to so much scarring that I have to check whether they got mucosal in the sinus because the whole sinus pathway was blocked. Do you have that experience? I mean, if they are in a remission, they are okay with sarcoidosis, but what is in the nose is complete scarring.
They do get some very dramatic stenoses of the nose and lateral wall with fibrosis, essentially, which can make it, very difficult for them to breathe. And I've tried all sorts of surgical maneuvers to try and enlarge the opening and putting stents and to be honest with you, it works for a bit, but it doesn't work long term. It's a problem. Once the patients start to develop this sort of process, it can be very difficult to arrest it. And again, it goes back to trying to pick them up early and treat them early.
You said that it's a limited area for surgery, but in sarcoidosis, this scarring with blocking the sinuses would be maybe a...
Well, you can cut it out, you can dilate it. It's a little bit like treating the laryngeal stenosis that you get in vasculitis. It has an effect, but unfortunately the effect is not long term. So, you have to get the patients to understand that you can attempt to enlarge things, but in the long term, the chances are that it may not last.
And do you also have the experience that everyone has Staph aureus in the nose who would be vegan? Well, if you check.
The Staph aureus story is quite a long one, actually. And it's why trimethoprim was given in the past as a treatment in low doses for GPA. It was quite the vogue, wasn't it, back in the 1940s, 50s, 60s. So
actually, Wegener thought Staphylococcus aureus is the cause of vasculitis.
And indeed, I have colleagues who used to regularly prescribe physicians mupirocin ointment to use in the nose against the Staph aureus. But my colleague here will know more about the etiology of this than I do, but I think it's maybe a factor. but it's not the only factor. It's a little bit like the Staph aureus story in the nose. It might be a precipitating factor, but once that process has been commenced, I'm not sure how much of a role the Staph aureus plays then.
Yes, there is a dual role for Staphylococcus. It was hypothesized that may have a pathogenic role, but also there is a common complication of treatment, of immunosuppressive treatment. So in all patients receiving cyclophosphamide or rituximab, a prophylactic dose of septrin is indicated. So everyone takes prophylactic dose of septrin. A few years ago, when I was registrar, there were some rheumatologists suggesting septrin as a treatment, as disease-modifying drug. That's why, because there was a hypothesis that it may be implicated in the pathophysiology. However, nowadays, this point of view is not so strong. So we give septrin only for, and it is supposed that Staphylococcus there is present due to the immunosuppressive treatment rather than as from the disease itself. So we give only prophylactic treatment in patients receiving very strong immunosuppressive drugs.
Okay, thank you. I thank the speakers. We are out of time now, and I wish you all a good lunch and see you later. Thank you.